Good afternoon, everyone. Welcome to this afternoon's deep dive presentation. I'm just going to start off with some housekeeping and announcements. But as you can see, we are discussing PNH today and diving into hemolysis specifically in this disease and the complexities thereof. And I want to welcome Prof. Murtadha Al-Khabori as our guest speaker, and I'll introduce him further just before he starts. So today's deep dive is sponsored by AstraZeneca. So I just want to thank them for that, and it's brought to you in collaboration with Blood SA, Sashas, as well as Assets. And we always thank our management team, Prof. Berg, Nicola Smith, Dr. Nicola Smith, and Nicola is the one who coordinates everything, and then Ms. Michaela Brooks, who helps with administrative duties. Some housekeeping notes. All the sessions are recorded, and you can find them on the Blood SA website under Resources Deep Dive. Just remember to mute yourself during the presentations, but you're free to add questions in the chat box. And afterwards, there will be time to ask questions in person if you so wish, and we'll respond to them or questions in the chat box at the end. CPD points will be submitted automatically to HPCSA for every registered South African attendee, and as long as you attend using your own Zoom link, and you must attend for at least an hour, and your HPCSA number must be entered correctly. If there's any questions, you can email admin@bloodsa.org.za. You can join the mailing list by scanning the QR code or going to the website to subscribe to Deep Dive. And we value feedback, so please feel free to give feedback afterwards. You will get as you log off, you'll get a feedback form. So yeah, those are the housekeeping rules. Just before we start, just a few notes on upcoming events. The Transkei branch of SAMA is presenting a college week shaping the future of myeloma care, and that is 18 and 19 February and 20 from 6 o'clock to 9 o'clock in the evening, as well as 20 February from 8 o'clock in the morning to 10 o'clock in the morning. You can scan the QR code for more information. Then remember about the joint SASMO-SASETS conference in the Sandton Convention Center from 7 to 9 August in this year. The early bird registrations end 31st of March, and then late registration you can do up to 31st of July. And then our 18th annual Heme Onc conference. This year it's a little bit later than normally, 2 to 4 October, and our theme is Beyond Boundaries, from Progress to Access. So everybody must register for that. All right, this brings us to our agenda for today. We've had numerous PNH talks over the past few years. Previously, we had very little experience in South Africa with treating these diseases with complement inhibition, apart from on a few clinical trials that we were involved with. But recently, some of these agents, specifically ravulizumab, and hopefully soon eculizumab, or ravulizumab is already registered. Eculizumab is available on Section 21 and hopefully will be registered soon. We have had some experience. I've personally got one patient on it. I know Andrew can't join today. He said he's got 3 patients on C5 inhibitors doing well. One patient does have, well, I'll discuss that later. But yeah, we are starting to get some experience. I would be interested, while we have the talk, those who have used the commercially available C5 inhibitors, if you could just post a comment in the chat box if you've used it. I'm not sure how many of us have had access. It would just be interesting to see. So yeah, we'll start with a discussion by Prof. Al-Khabori, and then we'll have a Q&A and I'll close off. So Prof. Al-Khabori is a professor of hematology at the Sultan Qaboos University as a senior consultant hematologist at University Medical City. He received hematology and bone marrow transplant training at Princess Margaret Hospital in Toronto, Canada, and research training at McMaster University in Canada. He's an associate editor of the Oman Medical Journal and has over 126 peer-reviewed publications in regional and international journals. He focuses on bleeding disorders, myeloproliferative neoplasms, acute leukemias, and allo bone marrow transplant. So thank you, Prof. Al-Khabori. It's a pleasure to have you with us, and we're looking forward to your talk. I'll end my share, and then you can share your slides.
Thank you, Prof. Mallory, for the nice introduction, and the Society for the invitation, and AstraZeneca for supporting this event. Now, let me try to share my... You can see my presentation now, right?
Yes, we can. You can go ahead.
So the title of today's presentation is Differentiating Hemolysis in PNH, but we will have some background about complements and PNH. Let me place a pointer. So disclaimer. And these are my objectives. First, I'll dive in complements, but not that deep, complements for the clinicians. And then through the discussion of complements, we will discuss PNH. And then we will go through the evolution of the complement inhibitors in the management of PNH. And then try to differentiate between different types of hemolysis that happens in PNH and how are they treated, specifically the breakthrough hemolysis and the extravascular hemolysis. And then I'll share one of the cases that illustrates first the heterogeneity of presentation in PNH and how can they be like complex, but also very, very interesting. So complements. So complements are a series of proteins that get activated, and one of their main functions is to fight pathogens. But they're also important in other aspects, like in inflammation. Now, classically, the complements can be activated by the classical pathway. And the classical pathway is usually activated after the immune complexes, antibody-antigen complex. So it is more of a specific immunity, adaptive immunity. That immune complex activate proximal complements, specifically C3 convertase, which later goes and activates what we call terminal complements, C5 convertase. After activating C5 convertase, you form membrane attack complex, C5b to C9. That membrane attack complex goes into the cell wall and produce cell destruction, inflammation, and also thrombosis. Some of these are directly mediated by the MAC, but some of them, like thrombosis, is also mediated by other things, like microparticles, activated white cells. So that's the classical pathway and how it activates the complements. Complement system can also be activated by lectin pathway. So lectin pathway identifies the carbohydrate on the microbes and through this activates C3 convertase. So it is more of like innate immunity. And then after the activation of C3 convertase, it goes down exactly like what you activate the classical pathway. So innate immunity, adaptive immunity, both can activate the complement pathway. Another important pathway in complements activation is the alternative pathway. An alternative pathway is a pathway that is active all the time. So it is like as if you have your car on all the time, and when you want to speed, you just accelerate, you press the accelerator. This is exactly what happens with the complements. So this pathway is important in the activation of complements, and it interacts with the classical pathway and the proximal and the distal complements. Ultimately, all of these funnel into the formation of the membrane attack complex, which leads to the outcomes that we've discussed: cell destruction, inflammation, and thrombosis. That's the complements pathway. So PNH is a disease where the regulation of complement is abnormal. So what happens, the inhibitors of complements are deficient, which leads to the uncontrolled complement activation. Now, that uncontrolled complement activation produce hemolysis when these things happen on the red blood cells, and that mobs down the nitric oxide, leading to the depletion, again, thrombosis and end organ damage. So, and controlled complement activation leading to all of these complications. Now, PNH, as we said, it is a disease where the regulation of the complements is abnormal. And it is not the deficiency of the complement inhibitors, it is the deficiency of the proteins, the chairs, the docking sites for the complement regulators. These proteins called GPI proteins. So these GPI proteins are proteins that are important on the cell surface that work like chairs for the complement inhibitors. And the gene behind these proteins is called PIGA gene. So PNH is somatic mutation, acquired mutation of the PIGA, leading to deficiency of the anchoring proteins. So on the left side, it is normal. The PIGA gene is normal, producing the GPI proteins, while on the right side, a patient with PNH with a somatic mutation, mutated PIGA. Now with this, you have on the left side intact docking sites and where there are complement inhibitors. And on the right side, when you have this PNH clone, GPI deficient cells, you cannot have your regulators on the red blood cells. And when you have uncontrolled, when you have complement activation, you cannot control it on the red blood cells, leading to the hemolysis, which what we talked about, leading to the different complications in PNH. Now, how do we diagnose PNH? So PNH over the years has been diagnosed with different methodologies, but the most recent and the gold standard of diagnosing patients with PNH is flow cytometry. And what flow cytometry does, it looks for the GPI anchored proteins on the different type of cells, and it identifies the loss of the GPI anchored proteins. So we are looking into the protein negative cells, not protein positive cells. So flow cytometry is the gold standard. And the International Clinical Cytometry Society did like a very nice comprehensive guideline, but the main core of the guideline to diagnose PNH, you need this 2x2 rule, which means that you have to have two cell lines that are deficient of those proteins with at least two different GPI markers per lineage. Now, classically CD55 and CD59, but there is a recent and a very sensitive reagent called FLAIR. And this is now the gold standard, if using 2x2, so two lineage, two proteins, and also including the FLAIR. Now, you could do a standard assay, a standard flow cytometry assay, which detects a clone size as small as 1%, which what you essentially need for clinical diagnosis of PNH. But there's also a high sensitivity assay where you do a lot of events so that you can get to a sensitivity of 0.01%. It's called high sensitivity assay. This is important when you want to monitor the clones when they are very small, or you want to detect clone in bone marrow failure syndrome. So in aplastic anemia, in MDS, where the clone is usually very small, that at times you need a high sensitivity assay flow cytometry. Now, we know flow cytometry can diagnose PNH now, but how do we classify PNH? You can think of PNH as the classical PNH. Let me stop this laser pointer because it's not working. So classical PNH. So classical PNH, and this is when you have classical florid intravascular hemolysis, which is the hallmark of PNH. PNH is when you have a DAT negative intravascular hemolysis with more or less normal blood film, like nothing specific on the blood film. Usually, because it's intravascular hemolysis, the LDH is very high. And usually the clone sizes here is more than 50%. On the other hand, you have subclinical PNH, where you have no major evidence of intravascular hemolysis. You have a bone marrow failure syndrome like aplastic anemia, and you have a small clone, usually less than 10%. Now, these are easy to classify. The difficulty, not maybe in classification, but also in the management. And when you have the overlap, you have a PNH with evidence of some intravascular hemolysis. So you have undetectable haptoglobin, high LDH, but you also have bone marrow failure. You have pancytopenia, you have hypoplastic bone marrow. And usually the clone size here is between 10 to 50%. This, although you can diagnose it if you suspect it, but you would have trouble whether you will need to treat that patient and how would you approach in the treatment. And the case that I would present at the end illustrates some of this difficulty. Now, that chronic hemolysis leads to the different complications in PNH. One of the most dreadful complications in PNH is thrombosis. Thrombosis could be arterial, could be venous, could be of different sites. Now, thrombosis itself increases the morbidity in PNH, increases the mortality in PNH, and also increases the mortality if you decide to do a bone marrow transplant for these patients. So a patient with thrombosis would have a higher treatment mortality if they undergo transplant when you compare it to patients who did not have thrombosis who undergo bone marrow transplant. It also can affect the kidney, leading to renal insufficiency, dialysis, and hypertension. And because of this chronic hemolysis, intravascular hemolysis, you have depletion of the nitric oxide, leading to the pulmonary hypertension and cardiac dysfunction. These are the different complications. Interestingly, the thrombosis in PNH is not the classical site. Although deep vein thrombosis are seen in patients with PNH, but it's usually the unusual sites. Budd-Chiari syndrome, portal vein, multiple site, mesenteric vein thrombosis. And if you look at these, they're different than the classical Virchow and the Virchow triad and the DVT. So the pathogenesis may be slightly different. And if you look at what is common among these sites, it's probably those sites that have low and slow blood volume flow. But it's not yet fully understood why PNH has a predilection to thrombosis in these sites. So this is about PNH. Now, if we thought PNH is a disease of unregulated and uncontrolled complement activation, logically, the the best way to treat is to inhibit complements. And this is where the complement inhibitors came. However, for a long time, we did not have complement inhibitors. We used traditional therapies to treat PNH. First, one of the standard of care is supportive care for anemia. If they have bad anemia, you give them transfusion. Some of them may have some bone marrow failure syndrome. You could give them platelet transfusion. So supportive care, specifically transfusion, is very important there. Also, complications management. So if they get thrombosis, if they get renal failure, if they get pulmonary hypertension, you try to manage these. These were the strategies that were used to treat PNH patients before the complement inhibitors. Immune suppression therapy, interestingly, was also one of the modalities used. Now, mostly when the PNH is associated with bone marrow failure syndrome like aplastic anemia. But sometimes steroids, historically and still maybe sometimes used currently, to treat like acute hemolysis in PNH. Sometimes steroids make a difference. However, as we all know, it's difficult to maintain steroids for a long time because of the complications of PNH. Allogeneic stem cell transplant was the mainstay, was the curative therapy for PNH. And when you look at the literature for allogeneic stem cell transplant, there was significant morbidity and mortality associated with the traditional transplants. Now, in centers that use myeloablative regimen and in centers that took patients that had thrombosis and maybe subclinical renal disease, the treatment mortality was high. In our center, we use a strategy previously, we use a strategy of reduced intensity regimen. Most of our patients were diagnosed early and selected for bone marrow transplant before they have evidence of thrombosis, and hence their outcomes were relatively better than what is reported in literature. But the transplant morbidity and mortality in literature is bad. So after the complement inhibitors came, our center, and I suspect most of other centers that had access to complement inhibitors, stopped using bone marrow transplant as a modality. Now we go back to the complement inhibitors. So the first drug that came was the eculizumab. Although in South Africa you had ravulizumab, I think approved before the eculizumab, but the first drug that came to treat PNH, which would change therapy of PNH, was the eculizumab. So eculizumab is a terminal complement inhibitor, is a C5 inhibitor. Later on came ravulizumab. Now, if you look at where can you put those complement inhibitors into the management of PNH? So you look at the PNH and you see, is there hemolysis or it is bone marrow failure? If it is bone marrow failure, aplastic anemia, you treat it according to the aplastic anemia protocol, so like immune suppression therapy or bone marrow transplant. If there is a component of hemolysis, you see whether they have symptomatic hemolysis, like anemia that requires transfusions, or symptomatic PNH because of other complications. So asymptomatic or symptomatic. If it is asymptomatic, you can watch and wait, but this needs to consider supportive care, prophylactic anticoagulation, because they would still be at risk of thrombosis. Also, I had a patient who had actually mild anemia, and we waited to start his complement inhibitors, and all of a sudden he gets flu, gets a bad hemolysis, acute renal failure, requiring dialysis in hospital for a month. You should be also careful in the management of asymptomatic patients with evidence of hemolysis. If they're symptomatic, it's probably more clear. And the symptoms here could be acute hemolysis, like recurrent acute hemolysis, or chronic hemolysis, or a thromboembolic disease. Now, with all of these, that would be an indication, and that guideline say eculizumab, but now we can also treat with the other complements inhibitors. In patients who had a thromboembolic disease, they would require anticoagulation. And the question now we can discuss in the Q&A whether they will need anticoagulation when they are on the complement inhibitors, that we can leave it to the discussion of the Q&A. Now, as we said, eculizumab made a big difference. And if you try to summarize the if you try to summarize the impact of eculizumab, the LDH was significantly reduced. So eculizumab was able to control the intravascular hemolysis. The hemoglobin has increased. Transfusion requirement has significantly reduced or completely ablated. However, there were like 15 to 20% of patients who continued to be anemic. Some of them required transfusion in the eculizumab. The thrombosis risk has also significantly been reduced with the use of eculizumab. The renal function has improved, and also the quality of life has improved. This is with the eculizumab. But with the eculizumab, we remained with two major unmet needs. One is there's still patients who were anemic, who were still requiring transfusions. And the second, eculizumab is an intravenous infusion that has to be given every 2 weeks. And with expensive therapies like eculizumab in countries like ours and many other countries, they centralize the PNH management. Now, in areas where you have home care, you could deliver it, but most of these patients come to our centers. And it was difficult to have these patients coming every 2 weeks for just their infusion and coming with like maybe 1 hour or 1.5 hours flight. So it wasn't easy that they get every 2 weeks. And that was a burden on the daycare when your numbers also increase. Now, later on, things evolved and the complement inhibitors also evolved, trying to address these unmet needs. One of the unmet needs that we discussed is the breakthrough hemolysis that happened with the eculizumab. And here we go into the second or the third objective of this presentation is differentiating and treating breakthrough hemolysis from also extravascular hemolysis. And how do we define breakthrough hemolysis? So breakthrough hemolysis is the definition of hemolysis leading to the reappearance of PNH symptoms, decreasing hemoglobin, and a rise in LDH. There are two types of breakthrough hemolysis: the pharmacokinetic breakthrough hemolysis and the pharmacodynamic breakthrough hemolysis. And we will start with the pharmacodynamic breakthrough hemolysis. So pharmacodynamic breakthrough hemolysis, and when you have a good drug level, but the level of complements increase. And that happens with major inflammation, vaccination, surgery, different types of conditions that lead to the inflammation. I mean, logically, it could happen at any time. And the best way, if you can, is to avoid that inflammatory state that leads to the pharmacodynamic breakthrough hemolysis, that leads to the increase in the complements, where really you cannot do much about it because you have that drug level, and it will be very difficult to increase drug level to match that increase in complements for a long time. So that's pharmacodynamic breakthrough hemolysis. The other type of hemolysis is pharmacokinetic breakthrough hemolysis. So pharmacokinetic breakthrough hemolysis is related to the low drug level. So you have stable complements and low drug level, they cannot inhibit that level of complements. So again, if you think of it, that should happen just before the next dose. I mean, not just, it could be before the next dose, but it's not chronic. It cannot happen anytime. It is when you expect that the drug level would go low. So classically, before the next infusion, a patient will come like a day or two before their infusion, and they would have symptoms of breakthrough pharmacokinetic hemolysis. And the way to treat this, the different ways, one is to increase the dose and keep the every 2 weeks intervals. The other way is to shorten the interval time. The third way, without the use of increased drug dose, you choose other drugs that have a longer half-life with better pharmacokinetic properties. And this is where ravulizumab came. So ravulizumab is an intelligent design and modification of eculizumab. They made the modification in a way that instead of having the drug given every 2 weeks, the drug is given every 2 months after a proper loading. And there are two trials that looked at the efficacy and safety of ravulizumab. The first trial is the study 301, which looked at the C5 inhibitor naive, newly diagnosed patients and compared the ravulizumab versus eculizumab. And if you see one of their major endpoints is the LDH, which is the main marker of intravascular hemolysis, it's also a major prognostic marker that is a target for your therapy. And if you look at it, both of them were very good in controlling LDH, ravulizumab and eculizumab. So a drug that you could give every 2 months would give you similar or even better than the eculizumab, as I'll show you later. So that's the LDH. And this is the other study, the C5 inhibitor experienced patients where they were on eculizumab, but here they were shifted to ravulizumab or continued on eculizumab. Again, the LDH, the ravulizumab was able to control the LDH in these patients who were given ravulizumab, and you get the benefit of giving them every 2 months. If you look at the other outcomes like the hemoglobin stabilization and compare, you see that at least numerically, the ravulizumab group had a better hemoglobin stabilization than the eculizumab group in naive patients. Also in previously treated patients, both of them were very good in stabilizing the hemoglobin. When you look at the thromboembolic and the major adverse vascular events, first, overall, as we previously said, eculizumab reduced that risk. Ravulizumab also reduced that risk. And if you want to estimate that, it will be 0.7 to 1.4, so an average of 1 per 100 patients' years. And if you look at the other major adverse vascular events with the extension up to 6 years, you see that in both groups, in those who were naive and in those who were experienced before to eculizumab, comparing the MAVs, the C5 inhibitors were able to reduce the risk of major adverse vascular events significantly. So also it also works for the events. Now, if you look at the transfusion, this is transfusion reduction of transfusions. And here at baseline, as you would expect, only 25% maybe were not requiring transfusions. And after you started ravulizumab, you were able to increase that to almost 75%. But you're still left with some percent of patients that were still, they did not have much of reduction in the hemoglobins. And on the open label extension up to 4 years plus, that rate of reduction of transfusions stayed more or less the same using the ravulizumab. This is also in both groups, those that were previously naive in the previous slide and those were previously treated. As we said, ravulizumab had pharmacokinetic properties with a better drug delivery. So here you see, this is the level of C5 concentration. And the dotted line is the line where you effectively inhibit complements. The figure on the left side is the figure the figure on the left side is the figure on ravulizumab, and the figure on the right side is the figure on eculizumab. So on eculizumab, you see many patients with different time points that had free C5 higher than what you would think is an effective inhibition of the complements. And once they shifted to ravulizumab, most of these, if not almost all, disappeared. And in patients who were started on ravulizumab and continued on ravulizumab, you essentially had effective complement inhibition in most of these. That tells you that the ravulizumab has a good pharmacokinetic properties. So here, at least from breakthrough hemolysis, because of pharmacokinetic properties, you are able to meet or at least add some benefit to the breakthrough hemolysis. Now, The next problem that is still stayed, or the unmet need, is the extravascular hemolysis that ravulizumab, the C5 inhibitors, were not able to deal with. And to explain the concept of intravascular hemolysis, I want you to look at the diagram. So PNH is classically intravascular hemolysis. And what it happens here, patients would go into this intravascular hemolysis because of this MAC. Now, when you use a C5 inhibitor, you effectively inhibit the formation of MAC. However, C3 convertase remains active. And you have these C3 fragments, specifically here C3b, that would opsonize the red blood cells. And here you would have red blood cells that are opsonized with complement fragments. And when these cells go through the reticuloendothelial system, they are identified in a similar way that happens with worm-type autoimmune hemolytic anemia, and they would go on like extravascular hemolysis in the reticuloendothelial system. Now, how can you find this? If you do flow cytometry and try to look at the C3 loading on these red blood cells, you could do that. But flow cytometry is not available in most of the centers outside the research centers. So how can we diagnose extravascular hemolysis? And the minimum that you need to diagnose this is a patient with anemia with evidence of chronic hemolysis. So low anemia, low haptoglobin. LDH is high, but not very high to suggest intravascular hemolysis. And a chronic hemolysis, not a hemolysis just before the dose, which what happened in breakthrough hemolysis because of the pharmacokinetic properties. So here it is more of a chronic hemolysis with not much of high LDH. Now, there are different trials that looked at this group of patients, and they had different criteria for defining this group. I'll just maybe focus on the hemoglobin criteria. So alpha trial, and we will discuss these in a minute, used 9.5 hemoglobin gram per deciliter. The iptacopan trial, the APPLY PNH trial, used 10, and the Pegasus trial using pegcetacoplan used 10.5 criteria. So these are the criteria in patients who have evidence of chronic hemolysis, anemia, and the other thing, can we really prove this? If you have flow cytometry, you could look at the C3 dosing, but one of the ways that we could do that is a Coombs test. So Coombs test, the polyspecific would tell you it's positive or negative, but the monospecific Coombs test would look at the different immunoglobulins and would also look at the different complements fragments. Now, in our monospecific Coombs test, we don't have the C3b, but we have C3c and C3d. And in the case that I'll present was positive. So maybe C3b is a friend of C3c and C3d. So if you find C3c and d, probably C3b is there. The other way that I use also a lot in patients that I know that have previously similar clone size when it comes to PNH. So their PNH clone is high in granulocytes, high in monocytes, and high on the red blood cells. And if I see a patient with hemolysis, with chronic hemolysis, anemia, and evidence of a clonal gap where the clonal size is lower in the red blood cells compared to the other cell lines, that may suggest, but not diagnostic. Actually, all of these, the flow cytometry, the Coombs test, even with this, it will not tell you this is extravascular hemolysis. So you have to put everything into the picture so you can diagnose. Actually, there may be a good, if you do flow cytometry, maybe up to 50% of patients would have evidence of C3 loading without extravascular hemolysis. So you should be very careful in the interpretation of these tests. Now, what do we do to treat these patients? So options are danicopan, which is a factor D inhibitor. It's an add-on therapy. to a C5 inhibitor, eculizumab or ravulizumab, pegcetacoplan, and which is a C3 inhibitor, and iptacopan, it's a factor B inhibitor. So iptacopan is an oral tablet. Pegcetacoplan is a subcutaneous infusion given twice a week. Factor D inhibitor is an oral tablet that you take with the eculizumab. Factor D inhibitor, dinicopan, iptacopan, factor B inhibitor, target the alternative pathway, where pegcetacoplan targets the C3 inhibitor. The Alpha trial looked at the efficacy of the danicopan. So patients were randomized to danicopan versus placebo, and the primary endpoint was after 12 weeks, and then were later on continued on the open label extensions. Twice a day three times a day. And if you look at the patients avoiding transfusions, danicopan was able to increase the proportion of these patients from 8.8 at baseline to almost 80%, statistically and clinically significant. While if you look at the placebo, it was able to increase it only from 17 to 27%. Classical placebo effect when patients getting into the clinical trial. But again, significant and clinical improvement in the patients avoiding the transfusions. When you look at the hemoglobin, again, you see the patients who were started on danicopan increased from 8 to 10 to higher, while patients who were continued without danicopan did not improve till where they crossed over to the danicopan arm, and it improved with time. If you look at the absolute reticulocyte count, patients who were started on danicopan decreased their reticulocyte counts, i.e. were able to control their extravascular hemolysis, while patients who were continued without danicopan did not have reduction in their retics till they were started on the danicopan. And also, when you look at the fatigue score, although there is a good overlap in the error bars, but you see a signal that their fatigue may have been improved with the addition of the danicopan. That's one strategy. It's an add-on strategy. You add danicopan to the C5 inhibitors. The other strategy is to use a single agent approach. And here, pegcetacoplan, which is a C3 inhibitor. So in that trial, again, patients were, first, they were given a combination. They were in eculizumab, not controlled. So they were given pegcetacoplan with the eculizumab. Later, they continued on either pegcetacoplan monotherapy or on eculizumab. And later on, everyone crossed to pegcetacoplan. Again, before they crossed, they were on the combination so that because pegcetacoplan may take time, so that you have both together, and then they go into pegcetacoplan alone. Again, hemoglobin improved from 8.7 to 11.9 or so. And after they continued on only eculizumab, their hemoglobin dropped. So clearly improving outcomes. When you look at the change from baseline, it is superior. Pegcetacoplan was superior. When you look at the freedom from transfusion, it was non-inferior. When you look at the change in the reticulocyte count, again, it was non-inferior. And when you look at the change in the LDH, it was non-inferior, and also quality of life using FACET F score, which was non-inferior. So also pegcetacoplan as a monotherapy. Apply PNH, use iptacopan. And just to summarize, so it's a randomized clinical trial. It's an oral therapy. Hemoglobin increased by at least 2 grams, 82% in iptacopan, while only 2% in patients continued on the eculizumab. Hemoglobin level over 12, again, almost 70% in iptacopan, 2% in continuation of eculizumab. Transfusion avoidance, 95%, 26%. And the increase in hemoglobin is 3.6%, well, more or less no change in the complement. So again, a drug that really works. So you have two strategies. You have a strategy where you decide to go with only monotherapy. And again, we can discuss the difference in strategies in the Q&A. versus a strategy that you add danicopan to the C5 inhibitors. The last part of my presentation is the case presentation. This is a young male in November 2014 who presented to a peripheral hospital with fatigue, dizziness over 3 weeks period. He was found to have actually pancytopenic hemoglobin of 6, platelets of 20, and also white count ANC of 0.7, but not very low. His LDH was 800 at that time. His workup was completely normal, and his bone marrow was relatively hypoplastic, but there was a relative erythroid predominance, so hyperplasia. So we know he has evidence of hemolysis, but also bone marrow failure syndrome. And if you look at the classification, it's a group that had in the middle. And when we did his PNH biflow cytometry, his clone size ranged from 70 to 77%. At that time, we started him on supportive transfusion, and he was actually referred to us, not for PNH therapy, he was referred for a transplant. When we did the HLA typing, we did not find a transplant, but we had access to eculizumab. But the problem, what to do with him? Now he has evidence of bone marrow failure syndrome and evidence of hemolysis. To lower his risk of thrombosis till we get him horse ATG, because horse ATG is not available. We had to order it with every aplastic anemia that comes, and it takes time. So we decided to start him on complement inhibitors. But before you start complement inhibitors, and this is true for all complement inhibitors, you need to vaccinate. At that time, we only did we did pneumococcal vaccination, but here you're also supposed to do meningococcal vaccinations, pneumococcal vaccinations, and we actually use 3. We also vaccinate for Haemophilus influenza now, and we started him on eculizumab. This is what eculizumab did to his LDH. Significantly decreases LDH, crashes LDH, but his transfusion requirements slightly improved with the red blood cells, but not much. And he continued to require platelet transfusion. By the time we got the horse ATG and we gave him, then he significantly improved in terms of his erythrocyte, his RBCs and his platelets and his transfusion. However, when we gave him immunosuppression therapy, we stopped his eculizumab. And with cyclosporine, with hemolysis, we did not want patients to have like a bad kidney injury. However, once his bone marrow started recovering, he went into a classical hemolytic PNH. This is when he was started on eculizumab, which again controlled his transfusions and improved his counts, improved his erythrocyte counts, and continued to do well. He's also interesting. Later on, other things happened, but now he's currently on ravulizumab every 8 weeks, doing extremely, extremely well. To summarize, PNH is a deficiency of the anchoring proteins that are the docking sites for the complement regulators. The gold standard of diagnosis is by flow cytometry. Remember 2x2 rule. C5 inhibition reduces LDH, stabilizes hemoglobin, prevents life-threatening complications. Breakthrough hemolysis management, if it is pharmacokinetic, you target that pharmacokinetic with increased dose, decreasing the interval if you're using eculizumab, or shifting to ravulizumab. The extravascular hemolysis could be managed by an add-on strategy with adding danicopan, or also using a single agent strategy like using pegcetacoplan or iptacopan. And with that, I would like to thank you for listening. I'm happy to take any questions.
Thank you, Prof. Al-Khabori. That was a lovely discussion and talk on the sort of more practical aspects that we still sort of don't deal with on a day-to-day basis. Just maybe a few comments before I open the floor for questions. I've also got some questions from my side. Maybe just to mention the eculizumab versus ravulizumab trial was a non-inferiority trial. Although, I mean, practically the ravulizumab is much nicer to use due to the long infusion rate. All we can say is they're probably non-inferior. I think maybe in the South African context, we obviously we're starting to get access to these drugs. The challenge is still cost, but I think one of the things that one must remember is that I think people who don't know, or the funders, they when you say, oh, they're hemolyzing and they need transfusions, that doesn't sound that serious, and they may not be that willing to fund this expensive therapy. But I think something that one need to highlight and stress is that PNH, untreated PNH, has a significant mortality, of 50% mortality in 10 to 15 years. So although many patients can live a very long time with untreated PNH, they can at any time, as you nicely highlighted, if they get an infection and get a severe hemolytic episode, they can have a catastrophic thrombotic event. And I remember a very young boy, 19 years old, that was referred actually for when we were on our PNH trial. We had a oral factor D trial available to us a few years ago, and the patient was screened and enrolled fine for the trial, and the day he was about to start, he had a massive thrombotic stroke and died. So I think when we motivate for these medications, I think it's important to highlight the relative rarity of the disease. So although it's expensive therapy, overall health economic impact and the overall system may not be that large, and that it's not only about avoiding transfusions, it's about preventing potential death that can come at unexpected times. So yeah, I think that's just maybe something I wanted to highlight. And just maybe to mention to those of us in the audience that see patients on medical aids, is that there is AICF support for ravulizumab, and hopefully for eculizumab once it's registered. It's pending registration, and while we don't have the proximal inhibitors currently registered in South Africa, may be accessible on Section 21, but it is also being submitted for registration. So we will hopefully have access to proximal inhibitors. I see there's Nicole Green has asked, so what tests do you routinely use in the clinical setting to monitor patients on complement inhibitors?
So patients who are getting on complement inhibitors will come. I mean, when they're on eculizumab, before they come for the infusion, they just get a CBC. If they have no symptoms, if they have symptoms, we would also look at their kidneys and mostly their kidneys and their electrolytes. Just we want to see whether that hemolysis affected their creatinine. But that was every 2 weeks. Between time to time, they get their full assessment. If they did not get their renal function, if they did not get their other organ function assessed. We don't routinely, but maybe you should also consider doing assessment for pulmonary hypertension. And the other thing that they also get is the updated on their vaccination schedule. These are the things that we do regularly on patients with PNH. If they drop their hemoglobin, and we cannot explain by a hemolytic process, either breakthrough dynamic pharmacokinetic or extravascular hemolysis, a PNH patient could evolve into a bone marrow failure, could go into like aplastic anemia or even MDS. So at that time, they may also they get a bone marrow to see whether this is the explanation for their anemia and not really the hemolysis. These are the routine tests that we do for them, and the vaccination, of course. But I want to give some comments about some of the so PNH. The risk of thrombosis is really high. It's one of the highest risk of thrombosis, and as we discussed, increase the morbidity, increase the mortality, also makes you difficult to treat this patient if you decide, let's say, to transplant them. The second thing, the effectiveness of anticoagulation, the primary antiprophylaxis, so the primary anticoagulation is not that good in patients with PNH. As we said, they have unusual site. It's probably a different mechanism of action. So anticoagulation may not be effective in treating these patients or decreasing the risk of thrombosis. And we see that the improvement in risk of thrombosis significantly decreased with the complement inhibitors. And the last thing I would maybe say that C5 inhibition is important in controlling most of the complications of PNH because it's mostly driven by the intravascular hemolysis. In anemic patients, because of extravascular hemolysis, it's important. But if you are able to control the intravascular hemolysis, a lot of this complication would have been taken care of. An anemic patient may be requiring transfusion between time to time can be managed, and the quality of life is also there. So it is good if you have access to either shift or add on therapy when you want to control extravascular hemolysis. But your primary, especially if you have limited access, if your primary goal is to control the intravascular hemolysis.
Thanks for that. And maybe I want to add on that is I think one must also remember the impact of quality of life for the things like headache, erectile dysfunction, dysphagia, fatigue. It can be very significant even if they're not very anemic. And I found that many of the patients that start on the complement inhibitor, within the first few days, they say, this is amazing. They feel normal again and are able to. The one patient I have on treatment has actually, his employer was in the process of medically boarding him, and we managed to sort of delay that while we waited for the complement inhibition. And because he was unable to work he was previously on one of our PNH trials, and when he came off, his hemolysis was very dramatic because of the large clone, and he couldn't work for the whole year. And then the moment we started him on treatment, he's back to work. So that impact on quality of life and these other nitric oxide scavenging symptoms can be very significant. Before I get to, there's some more questions in the chat box, but I just want to ask a question from myself in terms of maybe first question, in terms of, do you routinely monitor PNH clone size, or only in those patients where you see they have to look for that gap in the leukocyte versus red cell clone size, or is it just something you do if you clinically suspect significant extravascular hemolysis?
So when you start patient on complement inhibitors, you're protecting the PNH clone. So you would see that you're protecting that clone, and maybe the clone would go up, even especially the red blood cells if there is hemolysis. And this is also more pronounced when you target C3 inhibitors, that the PNH clone increases with time. We don't do it routinely. We do it on an annual basis, trying to look and hope that the PNH clone, with time, it would go into a remission. This is a very rare, this is relatively rare incident. It has been well described in literature, and we did not see it in Oman based on that. We have a limited number of patients on GIT, but we're looking to find one. There was a patient actually who came with uncontrolled thrombosis. Like a thrombosis, and we give anticoagulation, and there was another thrombosis. We just gave maybe a few doses of complements, and all of a sudden that disappeared. That patient also had a lupus with antiphospholipid. So we don't know whether that PNH clone, actually it was even 70%, whether it was a true clone or not. And with the steroids treatment, with the immunosuppression, that clone improved. So this is the main reason why we would do it annually. Plus, looking into like an academic center, we would do that. I also do it when I want to differentiate whether there is that clonal gap, that clone gap that may tell me that there is some intravascular hemolysis or still ongoing hemolysis in these patients. But it's not recommended. You don't need to do it. We do it in patients who have a small clone who are not on therapy that we want to monitor their clone. So before they get into a clone size that we think would increase their risk of thrombosis. And we know the clone size is correlated with the risk of thrombosis. So if, let's say, if they have a small clone size, not requiring therapy, with time, if their clone size goes up, before they get into a thrombotic event, we look into other things. And what to do, that's a different story. These are the like situations where I would do the follow-up PNH clone size.
Yeah. Then just back to the chat box. So Rita Governor is asking, she thanks you for the great talk. And she'd like to know if you routinely do PNH clone screening for aplastic anemia patients, which, I mean, we do. I think it's standard practice. You must do PNH clones in any patient where you consider aplastic anemia. I'm not sure if that's through the bank done in South Africa. We definitely do. I don't. Do you do it routinely in or?
Yeah, we do it routinely
Yeah.
for a number of reasons. One, a PNH clone is a predictor that they would respond to suppression therapy. Second, in younger patients, sometimes when we take them to transplant, when they present with aplastic anemia, classical aplastic anemia, we want to rule out Fanconi, like other bone marrow failure syndrome. And Fanconi tests take a little bit of time. So if we see a clone, a PNH clone, we tell this is immune mediated. This is not a bone marrow, like the inherited bone marrow failure syndrome. It's not Fanconi. And at least if we want to rush that patient for for a transplant, we could do that even before the Fanconi testing does. The only thing, I mean, the thing that we don't do, but now we will start doing, is to follow the clone size after immunosuppression therapy. So now what we do the PNH clone at diagnosis for aplastic anemia, but we don't monitor that clone size. So after immunosuppression therapy and after the count recovery. And I think it is still important now that we also monitor for the same rationale that we monitor the small clones, what happened with those small clones. And we would start changing that practice here.
Yeah, we've started doing that, and most of our PNH patients that we have in our clinic are actually a majority of them are ex-aplastic anemia patients that had an enlarging clone post therapy. The next question from the chat box is from Jasmine Ramia. She again thanks you for a brilliant presentation. She asks, in patients who remain anemic despite adequate complement inhibition and exclusion of bone marrow failure, the literature suggests iron supplementation and/or erythropoietin support. Just to note that PNH patients who hemolyze can become iron deficient because the loss in the urine. Then, given the inherent thrombotic risk in PNH, could erythropoiesis stimulating agents potentially exacerbate thrombosis risk in this population? That's the first question. Maybe I can answer that, and then we'll go to the next one.
So, I mean, iron deficiency anemia can happen, but in patients on complement inhibitors with anemia, most of these patients will be getting transfusions. So at least the ones that we have actually are on the high end, like when the iron overload, than on the iron deficiency side. Is that because it's most of their anemia because of the extravascular hemolysis and not the intravascular hemolysis? So they still keep their iron. Possible. But in patients who are getting transfusion, I think we are less worried about the iron deficiency. ESAs is erythropoietin supporting agents is a possibility, but I don't think it's that effective. Their theoretical risk of increasing the risk of thrombosis is also maybe not that high. It is not described, and when you compare the risk of thrombosis because of PNH to the risk of thrombosis in patients on ESA who still have low hemoglobin, I don't think the risk is that high. So I don't think we should be worried, but I would not, if I have access to other things, I would not do ESAs because I don't think they're effective in treating PNH anemia.
And maybe just to mention that most of the thrombotic risk with ESAs was shown in the renal transplant renal failure setting. So whether we can extrapolate that to other settings is I think relatively unknown. So Jasmine, second question, in patients with persistent hemolysis on C5 inhibitors, she doesn't specify now if it's intravascular or extravascular. Do you perform C5 polymorphism testing or directly to switching agents such as crovalimab or a proximal inhibitor?
So the C5 polymorphism is exceedingly rare, and a very good predictor that there is no polymorphism is the response in LDH. So if you start a C5 inhibitor and you see a major change in LDH, they don't have that polymorphism. Actually, when this is one of the techniques that we wanted to test at least for the first patient. This is what we were learning about PNH, about what happens. And it was part of the clinical trial. And we, even before they decided to test, they said because of that response in LDH, this patient does not have that polymorphism. So this is really unlikely. If there's no impact on LDH, I think it is worth testing for that polymorphism, because that would have an impact in what agent you would use later on. But in patients who have the anemia or getting the C5 inhibitors, if we think it is, if they're getting eculizumab and they are like breakthrough hemolysis, we would try ravulizumab for sure. I mean, all of our patients actually now were shifted from eculizumab to ravulizumab. But if they're still anemic, the two strategies that we would do is now, before we had access to danicopan, we use pegcetacoplan. And I can take, as the study suggested, it works. But now the newer strategy is to add danicopan, and you can think of pros and cons of each strategy. So pegcetacoplan is a C3 inhibitor. So when they come with breakthrough hemolysis, they really come with a bad breakthrough hemolysis. And you don't know how to manage this. At the end, you will need to give them a C5 inhibitors to manage their intravascular hemolysis, or now you could maybe add another dose of a C3 inhibitor. But their intravascular hemolysis is usually like bad because of the unopposed C5 activation later on and the lack of inhibition on the C5. The other benefit of an add-on therapy compared to like a single therapy is compliance. So let's say if you use iptacopan. So iptacopan is oral therapy. If for any reason they forget or they don't, or they get a bad gastroenteritis or they get admitted for anything else, they cannot take their oral therapy, you have nothing else. Here, at least you have a C5 inhibition with an add-on therapy and a factor D inhibitor that is on the proximal side. So if the add-on therapy does not add to the cost of your treatment, I think it's a better strategy than the single-on therapy, the single agent therapy.
You just answered the question that I was about to ask about the proximal your choice on proximal inhibition, and I've been wondering about that, and because I mean I think the compliance thing is critical, because I think the pegcetacoplan is a daily or a twice daily dose.
Twice a week.
Twice a week. Okay, but the other one, iptacopan, is a more regular dosing. So compliance is critical, and we also noticed this on our oral factor D trial, which is a daily dosing, that they're very, very reliant on compliance, and when they get, we had some significant breakthrough episodes with inflammatory conditions and so forth. So it seems like the preference is that the addition of a proximal inhibitor to a C5 inhibitor makes more sense. In terms of do you find that adds significant cost, or what's because the base C5 inhibitors come at a significant cost? How does it work in your country? Is it funded, the addition of the second agent, or do you have problems with that?
It is funded if you can justify it. And I think now AstraZeneca is working on a way that does not add much to the cost of the C5 inhibition, the ravulizumab. So for us, it's not a major burden adding the danicopan. But if you look at the cost of iptacopan, it is much higher.
Mm.
than even
Okay.
the other complement inhibitors.
Okay.
So
Yeah,
here,
mm.
yeah,
Okay.
please.
Excellent. No, thanks. Then, so Garrick asks if there's a subgroup of PNH patients in whom you feel confident attempting treatment discontinuation, and what would your stopping criteria would be? I think, I mean, apart from the patients who spontaneously remit their clone, personally, I would be very hesitant. But yeah, your thoughts on that?
Yeah, I would completely agree. It will be risky. Unfortunately, this is a lifetime therapy
Mm,
unless you
yeah.
transplant, or unless they get that magic of the spontaneous resolution of their PNH.
Mm. And also that period of stopping is very, very risky because they have huge clones, and then you stop, and then that's when we were in the unfortunate position where the trials we were involved with the oral factor D inhibitors were stopped by the sponsors, and all our patients had to come off therapy, and we had no access to any complement inhibitor for any of the patients, and every single patient had severe hemolysis, and we had 5 patients on, and 4 out of the 5 patients had thrombotic events during in the month or so after the stopping. So it's not a good idea to stop complement inhibition if once they're on it. Yeah, just from experience. Then there's yeah. So Cholofelo is asking where can he get hold of the presentation, and that's so the recording will be present on the Blood SA website. I'm not sure if Prof. Al-Khabori would be willing to share his slides, but you can ask him. And yeah, so the
Also on
next question
Spotify
is,
nowadays.
say
Spotify.
again?
Also
Spotify.
on
Oh, and
Spotify for
Spotify as
those in
well.
traffic.
YouTube
Okay.
and Spotify. No, Blood SA is getting with it. Is going with the times. It's very good. Then Nicola asks if is it useful to monitor PNH clones less than 1% in aplastic anemia patients. Um, my take is that you at least need to check that it's not enlarging because we have seen this. I think yeah that's what your thoughts on that.
I would agree. I mean, it is useful because it tells us that it is immune mediated. It's not like inherited bone marrow failure syndrome, and also for to monitor it. It tells us that if we decide to give immunosuppression therapy, sometimes in patients younger than 40 or 50 with a matched sibling donor in aplastic anemia. They are hesitant to go to a transplant because usually we would offer them a transplant, but if they have a PNH clone and they decided to go with a non-transplant strategy, an immune suppression strategy, we would probably be fine with this if they have a PNH clone, because at least we expect that the response would be better than if they did not have this. So all of these are useful information collectively to make a decision about the management of these patients.
Yeah. I just thought of another question regarding the proximal inhibitors. I mean, we know the data on the terminal inhibitors, C5 inhibitors, that they're effective. And actually, I think as part of your motivations to the medical aids or funders, to my colleagues here, is to mention that data show that patients on complement inhibition have an life expectancy are similar to age-matched control. This is versus the 50% mortality at 10 to 15 years. So it is very effective in terms of that. So, but do you have any concerns in terms of the proximal inhibitors in terms of as monotherapy, in terms of preventing the thrombotic complications?
Um, I think the data shows they are very effective also in preventing the complications. So
Okay.
from that perspective, I don't think one has an advantage over the other. I mean, here theoretically, if they come with intravascular hemolysis, it's usually a bad intravascular hemolysis. Uh,
Mm.
so at that time, if you cannot control it, or if these breakthrough intravascular hemolysis are frequent, then potentially the risk of thrombosis would be higher.
Mm. Yeah, that's an interesting comment. And maybe on that, just I had a thought on the pharmacodynamic breakthrough due to infection or viral infection. Is there any place for an additional dose in that period? You did mention that you can't really get the inhibition up, but have you ever thought of, do you ever give an additional dose of eculizumab during, if they do get a pharmacodynamic breakthrough?
Yes, we do. So these patients, if they come, we try to help as much as possible.
Yeah.
And I think in some situation it is effective. It all depends how much you're driving the complements versus how much you can give the drug. But if you this would be the peak dose when you give. And here I'm referring to the C5 inhibition, specifically eculizumab. So it will be like because this is what we would do. We would give just one additional dose of eculizumab in patients who are coming with intravascular hemolysis if they're getting the C3 inhibitors.
Okay. All right. Let's see. There were some other. Yeah. So Nicola, we don't have access to compassionate basis eculizumab, but we do have access on Section 21. But it is you need the funders need to pay for it. So that's how I've been able to get my patient, the one patient on, and as I mentioned, Andrew has 3 patients on. Nobody else mentioned that they had anybody on eculizumab, but there may be others. Just to mention that Andrew said that one of his patients he has on one of the 3 has extravascular hemolysis, although he's coping quite well, are considering maybe accessing danicopan for that patient. And then I think this is an important question, just so that everybody's aware that the vaccine schedule for complement inhibitors. I think it's critical, the meningococcal vaccines, and maybe just a comment for those of us in South Africa is that we are used to only having Menactra available, that is the meningococcal ACYW serotypes, and we previously did not have access to the serotype B vaccine, and which is weird because serotype B is the second most common serotype in South Africa. So the recommendation is, and Prof can correct me if I'm wrong, but the Menactra, the serotype ACYW, is every 3 years, and the serotype B, which is now available in South Africa, so just to note, is every 2 to 3 years. So it's a bit shorter duration, and then they get the meningococcal. What we do is the conjugate vaccine followed by the polysaccharide a booster 8 weeks later. One can consider repeating the polysaccharide in 5 years, but if you've had a conjugate, it's not really necessary to repeat. If you are ever only have access to the polysaccharide vaccine, that should be repeated every 5 years and not sooner. And then the Haemophilus influenza is generally a once-off vaccine if you vaccinate as an adult, and then yearly influenza vaccines. Anything else from the vaccine side to add?
I think that's yeah. In Oman, we don't have access to serotype B vaccine, but yeah, but I don't think it's that prevalent in Oman, so it's not as serious as in yeah.
Yeah, and maybe just to mention, and maybe you can comment on what your practice is, that if you look at the guidelines, that even if you're fully vaccinated, the recommendation is to be on prophylaxis, antibiotic prophylaxis for the duration of, because even though even fully vaccinated patients have a significantly increased risk of meningococcal sepsis compared to baseline. So the recommendations is that they on as long as they're on C5 inhibition, they get prophylaxis as well.
Yeah, I agree, and this is what we do also in Oman. We give them the antibiotic prophylaxis.
Okay. And then there's a question from Elena Cornelissen. She asked a question about counseling women with PNH about pregnancy in the area of complement inhibition, specifically regarding thrombosis risk and neonatal outcomes. And I think you can comment, but on that.
Um, so we would advise them for contraception if, but like at least in our region is young females, they would still
Mm.
maybe not follow the rules strictly. But of all agents, we're a little bit kind of comfortable now using eculizumab in these patients, which has the more mature data. Actually, this was one of the other reasons that we wanted still to include eculizumab as part of the our formulary in the hospital. One of them is just to treat those if they decided to go, to get pregnant, and also we used it for the post-transplant TMA.
Mm. Yeah, and I think the accumulating data and I mean, while this is a new drug for us, it's actually a very, very old drug. I think registered 2004 or 5, so it's more than 20 years old. So my understanding is that there's in general very good pregnancy outcomes, and it's now I think important to mention a pregnancy in a patient with PNH who's not on complement inhibition is very high risk. So, especially a hemolytic PNH. So, those are patients that I think, and we have recently had a patient known aplastic anemia who developed later on hemolytic PNH who became pregnant, and we were very, very concerned and monitor very closely because the pregnancy outcomes is much worse untreated. So if they're on complement inhibition, there's many, many reports in the literature of successful pregnancy outcomes. So, I think in general, the consensus is that the fetal risk is relatively low compared to the risk of having untreated PNH. That's my understanding at least. So I don't know if there's any other questions. We've had a very lively and good discussion. And I think I've asked all my questions. Oh, maybe the one thing, in terms of thrombosis, patients with known thrombosis, I'd like to hear your opinion. The one patient I started on eculizumab now had a pulmonary embolism during his coming off the oral factor D inhibitor, and but without any significant consequences. He didn't have any pulmonary hypertension, any long-term complications of the pulmonary embolism. He was on rivaroxaban, and I decided to stop his rivaroxaban when we started the eculizumab. So, but I think there can be some individualization. But I'd like to hear your take on it.
So, in patients who had an event before their treatment and now they're on therapy, I'll make a decision based on two things. One is how serious was the first event, and what could be the consequence of that event happens again. Because if it happens, it probably would happen on the same site. So, if it's a DVT or maybe a small PE, that's fine. But if it's like extensive cerebral vein thrombosis, hepatic vein thrombosis, a major mesenteric vein thrombosis, then I would be a little bit more anxious in stopping the anticoagulation. But that's one of the major factors that I use. The other major factor is how well they are controlled on the complement inhibitors. So if they are not well controlled and every now and then they come with intravascular hemolysis, I would probably still continue their anticoagulation. But if it's not a major site and with no major consequence and they're well controlled on their complement inhibitors, I would do the same. I would stop their anticoagulation after a good period of good anticoagulation.
Yeah. Okay. No, thanks. That is very clear. Thanks, Prof. Al-Khabori. That was a wonderful session, and I thoroughly enjoyed that, and I learned a few things, practical things, which I think is very helpful for us who's starting on this road. I don't see any other questions. There's just a lot of thanks. Everybody seemed to have enjoyed the session and the discussion. And I think just for us here in South Africa, we must fight for these drugs, and I think patients deserve treatment, and the data is very good. I mean, if we think that even in the state sector, the Hemlibra or emicizumab is technically available, this could be something that for the rare patient, there's not a lot of patients, and I think in South Africa we always we far behind with access. So hopefully we can fight for better access. But thanks, it was wonderful.
Thank you so much for hosting me, and it was really wonderful. I also learned a lot
thanks.
from the discussion.
Thanks.
Thank you.
So with that, if there's no further questions, we can end the session, and we'll see each other next week. I don't know what the session is next week. Nicola, what is next week's discussion? Do we have a topic for next week?
It's a multiple myeloma session by UCT.
Oh, okay. Okay, excellent. All right. Goodbye, everybody. Have a nice evening. Bye-bye.